Desktop 3 is a study of the use of secondary cytoreduction in recurrent ovarian cancer patients. And just as a background, in the United States, we don't traditionally do this, especially based on some data that was presented some time ago now, demonstrating that potentially we could hurt these women by operating on them for their recurrence. And that's definitely been the case in the United States. If you're not at a big surgery center, like a big Memorial Sloan Kettering or some kind of big center where they do really complicated surgeries, it's pretty unlikely that you would be offered a surgery for your recurrent ovarian cancer. We just didn't really think it was helpful based on studies like GOG 213 or other smaller research studies. So Desktop 3 was a European study where they looked at recurrent ovarian cancer patients who had a pretty strict criteria for offering them enrollment on this trial. And you have to give them credit for identifying this criteria based on Desktop 1 and Desktop 2, and then really using it in Desktop 3, because the fact that they came up with an objective assessment of who should have surgery is very impressive. So performance status of 0, no residual after primary surgical debulking. So no residual, that's important to remember. And then less than 500 cc's of ascites. So pretty much none to little ascites, an excellent primary debulking surgery with no gross residual, which is really a surrogate, kind of like a biomarker for a patient that has better prognosis, and then a performance status of 0. So pretty strict criteria. And for the recurrent ovarian cancer patient, that's pretty rare to meet those 3 criteria in my clinical experience. But if you meet those 3 characteristics, you were offered enrollment on this trial. I think it's important to comment here that it's careful patient selection, and that it's potentially not the majority of your ovarian cancer patients. If you met the criteria to enroll on the study, the chances that you were able to be reduced to no residual disease was about 2/3. About 2/3 of the patients were able to be cytoreduced to no gross residual. And the message here, though, is that sometimes those were big surgeries. So surgical expertise is definitely necessary, being in a big center and setting expectations with the patient that it's a radical surgery. But if you're one of those 2/3 that were able to be completely cytoreduced, your chance of, you had a survival advantage compared to women that were not taken for surgery. But that being said, only about 2/3 of the patients that had surgery were able to be completely cytoreduced. So about 1/3 were not. And it's interesting because that 1/3 that were not able to be cytoreduced, actually you hurt by doing surgery on them. So, they did pretty good in identifying who could be completely cytoreduced, 2/3 of the patients. But important to remember that 1/3 that essentially you messed up on, you didn't triage right, you actually hurt compared to helping them or making them do the same. So I think we need to better define potentially the selection criteria, because we definitely don't want to hurt 30% of our patients by operating on them. But if we can carefully select those 2/3, potentially we can help them. But I think the big kind of question for this study is that most of the patients, many of them, did not receive bevacizumab as a prior therapy, and then definitely really they weren't using PARP inhibitor maintenance therapy either. So, some question, the control arm, if the control arm for Desktop 3 had received bevacizumab, would they have looked better, or at least been the same as those that were completely cytoreduced, like the study that was performed in the US. So if you use bevacizumab in your practice, you don't really know if this study is applicable to you. definitely, if your patient has never gotten bevacizumab and they fit the criteria performance status 0, no residual after primary debulking, and less than 500 cc's of ascites, like I said, and just to emphasize, no bevacizumab. If they fit those 4 criteria, potentially you do need to get them to a center that does radical surgery and set expectations with the patient that there's 2/3 of a chance that she'll be able to completely be cytoreduced and have a survival advantage. So if you have that patient in your practice, this gives you justification for taking her for surgery or for recommending that. But if you use bevacizumab, you don't really know how applicable this study is to your patient population. And potentially those patients on GOG 213 that got bevacizumab, potentially those patients actually did better without having the surgery. And so we kind of have 2 experiences here. And I think the way I interpret it is, if I have a patient in my practice that has not had bevacizumab and fits all that criteria that we discussed previously, potentially I should get her set up for a radical surgery.